Hi, I am Andrea from PMD Alliance. So glad to be here hosting a session with one of our most trusted and appreciated physician advisors, movement disorder specialist, Maria Cristina Ospina. And so good to see all of you. So, a couple housekeeping items. This is being recorded. So, sit back, soak it all in. You can always refer back to the recording afterwards. You can also turn on the transcript, turn on the closed captions, however you learn best. Please customize. And one of Dr. Ospina's one of our most valued traits is she loves spontaneous questions and interaction. And we want to, I told her this chat is going to be hopping. People are going to bring their questions. And that's exactly why we decided on this topic and this program. So I see Mickey took the words out of my mouth. Let's get some practice with our fingers. And yeah, please add in the chat, where are you joining from this midsummer afternoon? Hopefully the weather's better than where I am joining from in Phoenix, Arizona, where it's 101 million degrees outside. So put in the chat where you're tuning in from. And while you do that, it's my pleasure to introduce you to our movement disorder expert today, Dr. Ospina. So, Dr. Ospina, I know the answer, but tell us where you're joining from.
Sure. Nice to see everybody. So I'm also in Phoenix, Arizona, where it's 1.5 million degrees outside in July. At least we have air conditioning, so we're grateful for that.
Yes, welcome, welcome. And before we get things started, I wanted to tell you all just kind of the genesis of this program and a lot of our online topics. They come from neurologists like Dr. Ospina who say, I'm getting this question or this topic over and over in clinic. And if my patients have questions and want to know, your community does too. So let's get online, let's open up the lines of conversation. And she offered herself, let people pick my brains. What do you want to ask your doctor, but you don't have enough time, or you don't have another neurology appointment until 9 months, or maybe you just came up with the question, in the last week out of symptoms or things you've observed. So, to get things started, Dr. Ospina wanted to start with some foundational knowledge about dementia, about cognitive decline and normal aging, and the Parkinson's brain. So, hopefully that's a good lead in for how you want to get things started, Ospina, but I'll turn the floor over to you to take it away.
Great, thanks, Andrea. So as Andrea was saying, yeah, this sort of webinar came about because about a month ago, I had like a whole week of patients with dementia, and I felt like they just have enough time in the clinic to ask their questions and to me to go over all of their concerns. And so we thought that we would do a webinar where you guys would have time to ask any questions that you had about Parkinson's, PD medicines, and specifically dementia. And so what's different in dementia versus Parkinson's disease? So remember that Parkinson's disease, we tend to think of it as mostly a motor disease, looking at the tremor and rigidity and trouble with gait and balance, but that's really only sort of like the tip of the iceberg. Under that is all the non-motor symptoms of your Parkinson's, and that's everything from losing your sense of smell to constipation to anxiety, depression, REM sleep behavior disorder, and of course, cognitive impairment or dementia. And although our medicines for PD make your motor symptoms of PD better, it helps the tremor, it helps your rigidity, it helps your gait and balance, they all make your symptoms, your non-motor symptoms worse. So the levodopa helps the tremor, but it makes you more orthostatic. It lowers the blood pressure and can lead to dizziness and falls. It can cause more confusion and or hallucinations. It can make you compulsive. And so our job is to try to get that balance just right, that you have enough meds on board, that you're mobile, but that not that you're fainting every time you stand up or that you're confused or hallucinating uh, on the medicine. And with Parkinson's, you have bradykinesia, which means slowness of movement, but you also have bradyphrenia, which means slowness of thinking. And you can notice that that waxes and wanes throughout your day as your medicines kick in and then trough, peak and trough. And so that's why we like to use longer acting forms of your levodopa like Crexont versus immediate release levodopa, so that we can keep you on for 4 to 5 hours instead of 2 to 3 hours, or put you on a pump where you're on most of the day and have very short troughs just because you ate something or went to rock steady boxing. But you'll notice that just like there's a waning in motor skills like gait and balance and stiffness and rigidity, non-motor symptoms can get worse during that time, like the bradyphrenia, the thinking. And so many times those non-motor symptoms are your first sign of off, like the anxiety before your tremor comes back. And many times it's the caregiver who says, oh yeah, I can always tell when the medicine wears off because I'm speaking to him, I'm asking him questions, and he sort of stares at me blankly and takes a long time to process the question and answer back. That's the bradyphrenia. And sort of like a quick, and then, like what's normal aging and what's Parkinson's disease? And so, we all forget words and we all forget, where we put the car keys. That's sort of normal ages, well-used Post-it notes. Dementia is you found the car keys and you don't know what to do with them. You don't know what they are and how to use the car keys. So that's dementia. So kind of think of that as a quick and easy way of, what's normal aging, I'm forgetting stuff, and what's dementia. And now it's a little bit harder now with all of like the new TVs and smart TVs that connect to your internet and send you text messages. And, you can't really quite say if the patient can't use the TV remote, is that dementia, or is it, or is it that you need your 8-year-old grandson to come and help you turn the TV on? But before, 20 years ago, when it was just like an on-off button, that would be a quick and easy way. Like you can't use the TV remote. Okay, that's dementia. Today, I can't really use that. So let me, I'm really here to answer your questions. So I'm going to open up to you guys and ask me anything about Parkinson's, PD drugs, dementia, all of that stuff.
Okay. And while you guys are formulating your questions and putting them in, I have one to get started. Someone wants to know, what is executive function? Is that the same as dementia? And how does Parkinson's affect it?
Yeah, so executive function. So the frontal lobes, this part of your brain is sort of the important part. Like that's what makes, keeps your calendar and makes plans and plans ahead and has good judgment. And if that gets disconnected, then you start to have poor judgment and you're not able to plan ahead and make good decisions. So it's like, I'm going to have to go to the dentist. I'm going to plan it on a day that I'm not at work, or I'm going to ask my, boss for that morning off so I can go to the dentist. And so that planning, sort of executive function, that's what we call it, planning ahead and sort of being able to manage your affairs. Not necessarily like balancing your checkbook, but able to plan ahead kind of thing. And then that many times, along with things like short-term memory loss, word finding difficulty, what we call executive function, then starts to become more impaired in dementia.
And that is Parkinson's or just
But
aging or both?
well, so no, a 90-year-old with, connected frontal lobes is not going to have executive function problems. So they're going to be able to keep their calendar, plan their appointments, make sure that they get to their appointments on time, make sure that the oil is changed in their car. But as you develop mild cognitive impairment and that progresses to dementia, then those sorts of things become harder to do, not only because you lose your short-term memories, you can't remember what happened yesterday, and that they gave, they told you you need to go make a dental appointment, but you can't really figure out, looking at the calendar of like, well, when should I do that? And what would be a good day? Oh, on a Sunday, that's probably not a good day because they're not going to be open. Does that make sense?
Mm-hmm. Okay. Thank you. So our friend Larry in Palm Desert asked, can you speak more about how Parkinson's medications can increase or worsen cognitive issues? that information is new to him.
Oh, so yeah, so increasing dopamine, it's helpful for our motor symptoms like tremor, rigidity, and gait imbalance. So help you to move around. But if we have too much dopamine in the brain, then that can cause confusion, it can cause hallucinations, it can cause impulse control disorder. So remember that the drugs that we have today are not selective. They don't just hit the D2 receptor, which is what we need for gait imbalance. They hit all of the receptors like D3. And so not only do we have improvement in your motor symptoms, but we also can make you compulsive and we can make you hallucinate because these drugs are not selective. So eventually we'll get drugs that are better tailored and they only hit one receptor, the one that we need. Right now they kind of, it's like a big spray and it hits everything.
Mm. Okay, Larry, if you have more follow-up questions, put them in the chat. Doris wanted to know what tests determine dementia.
So many times we'll do neuropsych testing, and it's kind of like we'll do like a quick test in the clinic where it's mini mental, and we ask you, what the date is and who the president is, and some math and memory, remembering five words and drawing a clock and that sort of thing. And then there's a much more specific test called neuropsych testing. It's kind of like an SAT test, like it's 3 to 4 hours and it's pencil and paper. And it looks at more reading comprehension and those sorts of things. And those are the kind of tests that we do before you go get DBS or deep brain stimulation surgery, because we know that that surgery makes dementia worse. So we want to pick it up early before the surgery, before we drill 2 holes in your head and poke it with a stimulator. Then we eliminate patients who have MCI or dementia with the neuropsych testing. So many times we'll do that before, and then we can do serial testings every year. But usually if you have Parkinson's disease, then we know what the dementia is from. It's the Parkinson's disease, and we know what it's going to look like. But although the dementia, looks different when we look at the brain under the microscope. In Parkinson's, it has Lewy bodies, where in Alzheimer's, it has beta amyloid plaques. For the patient and the caregiver and the clinician, it's pretty much the same cognitive impairment. It's the same trouble with executive function and activities of daily living. You can only really tell like what's one under the microscope, but the treatment is the same, and sort of the patient's experience of dementia is pretty much the same. So in Parkinson's, you tend to have a little bit more hallucinations and waxing and waning of the symptoms because of the peaks and troughs of the medicine.
Okay. And that's a good segue to a question from Teresa. Does Seroquel cause mental impairment? Her loved one was put on Seroquel to deal with hallucinations, but cognition has become impaired and he has plummeted quickly and is acting very demented.
Yeah, so Seroquel is an antipsychotic that we use a lot in Parkinson's disease to help with the hallucinations. So we know that when patients develop hallucinations, those Lewy bodies have reached the cortex, sort of the thinking part of the brain, and that cognitive impairment, dementia is soon to follow after that, and that we have to use these sorts of medicines that block dopamine, make your motor symptoms a little bit worse, to keep the mind as clear as possible. But these medicines aren't without side effects. They do cause lethargy and sedation. So we usually tend to use them at night. But it's not unusual for patients that use Seroquel to have more sedation, impairment, sort of sleepiness. But we have to think like, do the benefits of the medicine or therapy outweigh the side effects? So is it better that you're a little bit sleepy and sedated, or that you're very anxious and worried that there's men in the house and you're calling 911?
So maybe talk to your doctor about the side effects so your doctor can help evaluate the
Right.
pros and cons.
Right. And remember that if not everybody with Parkinson's disease develops dementia, but let's say you have dementia, it's progressive in the same sense that the motor symptoms are progressive, that with time you notice that the tremor started on one side and then 5 years later it's on the other side, and now you have trouble with gait and balance. And as the disease progresses, you have more disability with it. The non-motor symptoms, like the cognition, are also progressive, so that with time, before it was just forgetting some things, but as the disease progresses, the dementia progresses as well. And so that your loved one needs more help with activities of daily living, more care at home. And certainly that's not something that can be done by one person in the house, because you need to sleep at night and you also need respite care. And so that the more that you plan ahead for these transitions, the easier it's going to be. And then you'll also notice that even very minor things like you got a UTI or you went to Flagstaff for the summer, any change of environment can trigger more confusion and or hallucinations. And so that you want to be mindful of those things, that the body doesn't deal with stress as well as it used to.
Okay. Glad you brought up care partners needing to sleep.
Sleep, right.
There was also a question about the effects of sleep and insomnia on thinking. So this person said their husband only gets about 4 or 5 hours of sleep a night. His thinking process is good at times, but then sometimes he gets confused about, for example, his chair remote or his glasses case. It's scary for him when he worries about losing his mind because he's not sleeping. So what is that comment? I don't know, what would you tell that patient if they shared that in your clinic?
Yeah, so sleep fragmentation is extremely common in Parkinson's disease, and patients have trouble sleeping for many reasons. So the number one cause is sleep fragmentation. You're running out of dopamine in the middle of the night. Your body gets rigid and stiff and wakes up and can't relax enough to fall asleep. So there, what we need to do is give you dopamine that's going to last throughout the night. So use a medicine like Crexon or add a dose of your levodopa in the middle of the night to keep that gas tank full, so that you're not waking up because your medicine is wearing off. That's one of the pluses that we've noticed with Vyalev, that patients were using the pump throughout the night, they're sleeping better and they're waking up on. And of course, the better sleep they have, the better their next day is, the better the brain is, cognition, that sort of thing. Then you can also have fragmented sleep because you have restless legs and you can't fall asleep because the legs don't let you. So we can treat that with a small dose of a dopamine agonist at night. You can have REM sleep behavior disorder, where you're woken up because now you're acting out your dreams and falling out of bed, or hitting the lamp with your arm, and that wakes you up. It's usually waking up the care partner more than the patient, but that can be a cause for disrupted sleep in Parkinson's disease. And you can have obstructive sleep apnea, central form, which is seen in Parkinson's disease, that you're not getting enough oxygen, and so you have apneic spells. And so we treat that with getting a sleep study and then a CPAP machine or a BiPAP machine. And then what happens with many PD patients is that, remember that these medicines that you're on all make you sleepy. All forms of levodopa make you sleepy. All dopamine agonists make you, all your PD meds make you sleepy, and you're taking them throughout the night. Throughout the day. So if you're taking Cinemet 5, 6, 7, 8 times during the day, you're getting sleepy, you're taking naps, and then these naps get longer and longer. And then some people switch their sleep-wake cycle. They're asleep during the day and then awake at night. And so then, of course, that's, the caregiver is trying to sleep at night, and then you have 2 different sleep cycles. The other thing that can happen in Parkinson's is that, let's say we added too much dopamine and now we've made you a little bit manic and a little bit compulsive, and you can develop what we call punding behavior, where you're constantly organizing, shuffling papers and organizing stuff, and you won't go to sleep because you have to do stuff like clean and organize. And so that keeps patients up, or they're on the internet shopping on Amazon or porn or that sort of thing. And so then they're not sleeping for that reason. And so then we have to pinpoint what the reason for not sleeping or the insomnia is, and then treat that instead of putting a Band-Aid over it and saying, here's some Ambien, let's make you sleepy. We want to treat the cause. So the most common cause is to keep that dopamine throughout the night. And that's why the pumps are so successful in allowing people to have less sleep fragmentation. The other thing that's a plus with keeping you on and using the pumps is that non-motor symptoms, like your urinary urgency, so that you're not getting up and going to the bathroom 4 or 5 times a day and having that bladder wake you up. if we can keep you on, there's less of that urgency and it doesn't wake you up so many times at night.
Parkinson's is so complex. I mean, just having to tease out why the sleep is,
Right.
interrupted is, I mean, that's like a full office visit right there.
Yeah, that's a full office visit right there. Exactly. So that's why I feel like, gosh, if you're only getting 15 minutes in the office, it's just not enough.
It's not
Uh-huh.
uh, which why we're very glad you're here offering your expertise. Okay, so I want to piggyback off of what you were talking about with the consistent dopamine levels or levodopa levels. So Erin is in Canada, and Erin says in Canada we don't have many long-acting PD meds available like the US does. So many of us are on high and frequent doses of immediate release Cinemet. If that's exacerbating bradyphrenia, bradyphrenesia, and understanding your environment, what are some options?
So I think, yeah, so I think that Rytaria is not available in Canada, but I think that Crexon is slated to come to Canada and Europe. So once you guys get Crexon, it's going to work a lot better than what you have now, that 5200 Cinemet CR, which patients call crummy release, because it's not really an extended release or a long-acting form of levodopa. But what you can do is leverage other drugs. So you can use other drugs like dopamine agonists that are 24 hours, Mirapex ER, those, or Nupro patch, so that you have some kind of dopamine therapy on board in the 24 hours. And then I'm pretty sure that you guys probably have access to Duopa, which is one of the pumps, but the patients don't like it because you need a PEG-J. But we had that here and we would run our pumps 24 hours a day. So you just leverage what other therapies you have to get more continuous dopamine tone throughout the night. And then you can use dopamine agonist, and a tavapadon will become available next year. I'm not sure if it'll come to Canada right away or not, but that'll be also once a day oral dopamine agonist. But I'm pretty sure that you guys are going to get Vylev. If you don't have it already, it should be coming soon because it's pretty much available in the rest of the world, Europe, Japan, Australia. So I would be surprised that it's not going to come to Canada.
Okay. And question about the other pump, the apomorphine
Uh-huh.
onapgo pump.
Mhm.
Does the continuous infusion help with the round the clock and sleep, um, like the Vylev pump that
Yeah.
you've referenced?
So ANAPGO or apomorphine is a pump that's available in the US, but in the US, it's only available as an adjunct therapy 16 hours a day. But in my experience, we have patients on both pumps. And so actually one of my last apomorphine pumps, she's only using it during the day, but now she's sleeping a lot better. And that, remember, we talked about that urinary urgency, that's also gone a lot better, even though she's taking it off at night. So as we get more better dopamine tone and more consistent dopamine tone, just like Duopa, many of our Duopa patients didn't need to run the pump. Duopa in the US was also approved only for 16 hours, but we ran half of our Duopa pumps 24 hours, so sort of off label. But many of those patients who would take it off at night, they slept a lot better. So we're going to see better sleep control, whether or not you're going to run your pump 24 hours a day. But I think the new paradigm is going to shift, that we're not going to use as much polypharmacy, as that Canadian patient said, it's hard to take medicines throughout the day and then also at night, anytime you wake up, to take another dose of levodopa. Now that we're getting longer acting forms of levodopa, we're going to be on Crexont, 4 times a day. And then your 5th dose of levodopa is going to be a pump. And our job is to keep you in that therapeutic window where you're not peaking and troughing above and below your therapeutic, where you're on all day, and continuous. So, what causes the disability in Parkinson's disease is those motor fluctuations. And of those, the trough, the off periods cause more disability than the peaks, that on time with dyskinesia. So if we can eliminate those peaks and those troughs where you're off and then on with dyskinetic movements, then the better off your day is going to be, because we're going to make your day predictable. You're not going to be planning your day around every single dose of levodopa. And remember how we said that you can have bradyphrenia? So just like you're going to have less bradykinesia, slowness of movement, if we can keep that brain on, you're going to have less bradyphrenia. And we're not going to have the brain on and off for 10 years before it becomes demented. It's just going to be on. So I think that we're going to see that patient, that we're going to extend that honeymoon period that we see initially with Sinemet when you first start levodopa, to extend way past 5 years and be, a much better experience and more predictable experience with Parkinson's disease, the better we get these therapies.
Thank you. Okay. I'm going to combine two questions from Betsy and iPhone 10. So, does everyone eventually develop dementia if you live long enough? And what percentage of people with Parkinson's will develop dementia? And is it inevitable?
So I mean, we can't say that it's inevitable. We can't say, well, gosh, is it the 80-year-olds, they just didn't live long enough to get, dementia? We do know that alpha-synuclein acts like a prion, that it goes from one cell to the next, and that's how it sort of climbs up the vagus nerves and gets into the brain. And so we would think that if that is true, that then as it keeps spreading and then gets to the cortex, that everybody's going to get demented. So it all depends that when you get Parkinson's and how long do you live with Parkinson's disease. But there's many people who live 20 years with Parkinson's disease that don't have dementia. Remember, everybody's different with PD, and everybody's response to medication is different. So I wouldn't say that yes, everybody's going to get demented, but we don't know the answer to that.
Okay. And okay, question about young onset Parkinson's. So, are there different patterns you see with people with young onset Parkinson's and dementia? And if someone with YOPD develops dementia, does it tend to be in alignment with years since diagnosis or age?
So there's so many confounding factors. So remember, there's so many different reasons why you can have PD and so like young onset, are you a Parkin mutation? Are you a GBA mutation? Those are going to have sort of different phenotypes. So we know that Parkin mutations, they do quite well for a long span of time. We know that the GBA mutation, they're more likely to have dementia than other forms of Parkinson's disease. But certainly, the longer you live with Parkinson's disease, the longer you have time to have disability with Parkinson's. So getting Parkinson's at 40 is very different from getting Parkinson's at 80, because you've got another, 40 years to go with the disease. But there's different flavors of PD. So, it all depends, what's your gene mutation and what's the environmental trigger that, turned that gene on. Are you going to be more orthostatic? Are you going to have more dementia? Are you going to have more impulse control disorder problems? Are you going to be more tremor predominant, more rigid predominant? So we can't say, it's like one size fits all. And we just have to sort of see how, the patient evolves and develops and manage them as best we can.
And is that the future where there's, okay, you have the Parkin gene, so you have this flavor of Parkinson's, and this is going to be, your trajectory. Are we there yet?
So no, we're not there yet, because most of the time when we do gene testing on Parkinson's patients, they don't pop up, not even with the 7 most common genes that we know in Parkinson's disease. So it's usually young onset PD patients that pop up with one of the genes. But if you're like a 70-year-old, 75-year-old, most likely, and you do the PD generation test, most likely it's going to be negative. So we're not there yet, but it's intriguing. We're certainly doing clinical trials with like LRRK2 patients, that sort of thing. But I think that once we get a disease modifying therapy, something that we could stop this alpha-synuclein from spreading in the nervous system and slow it down, that'll make a huge difference. And as we get better therapies like the pumps and longer acting forms of levodopa, so that we can keep the patient within their therapeutic window for years, a lot longer, and not having these constant motor fluctuations, and having your day be more predictable, that PD will turn more into what MS looks like today than what PD was 20 years ago. I mean, you can already see it. I mean, in this, if you go into a support group today, almost nobody has dyskinesia. Whereas if you went into a support group 20 years ago, every single patient would be kind of wiggling out of their chair. And now with the advent of these pumps, we're going to see that we're going to be keeping people on and with less fluctuations, less disability, as long as they're able to tolerate the pump.
Sounds good. Okay, I don't know if you can answer this one, but Alita wondered, her PD support group wants to know why cause of death for someone who passed away was labeled dementia, not Parkinson's.
So dementia, I mean, patients with dementia, they die because they aspirate, so they can't swallow, they aspirate and they develop a pneumonia, or they have a UTI and it sort of spreads and they get sepsis, or they have a fall and then they get an infection. So, dementia is not sort of the proximate cause, but it's what led to aspirating or getting a pneumonia or being more susceptible to an infection like COVID. Many times you'll see they'll just sort of do a shortcut and be like, oh, patient Parkinson's death, cause of death, Parkinson's disease. But that's not really why they died with Parkinson's disease, just like you die with diabetes. It's not the proximate cause of death is usually either a heart attack or a stroke or an infection or aspiration pneumonia, those sorts of things.
So hopefully that answers that or gives some light to Alita. Okay, so let's see. Okay, so this is a question about tips on how to deal with behaviors. So let's see what you got for this, Dr. Ospina. Okay. This person finds rationalizing with their loved one with Parkinson's about cognitive decline feels useless. They understand that they're physically declining, but in denial about the cognitive decline. So, for example, a loved one with Parkinson's was cleaning the car wheels with a kitchen towel. When asked why, they were clueless. So, any tips on behavior like this? Just no insight about the cognitive decline.
Right. And then in Killian, and we had there's a little handout that we have that I think you were going to put in the notes or in the chat, sort of like tips of dealing with exactly these kinds of things. So you always want to go along to get along. So remember that we talked about the frontal lobes, they're now disconnected. They're not connected to the rest of the brain. And so they can't rationalize with you. So before you'd be like, oh, that does, why don't you use this kind of towel, with the car? This is what we use to clean our dishes. We don't want to be using it on the car tires. And it would make sense to the patient because their frontal lobe was connected and they could make a rational decision. But remember, once your brain is disconnected and those little networks are kind of falling apart, you can no longer rationalize with that patient because they no longer have insight into their disease or their hallucinations. And they're no longer able to rationalize like problem solve of what's happening in their sort of world. And remember, their reality, like when you talk about hallucinations, these hallucinations are generated by the brain. So the optical part here of the brain. So their brain is seeing those hallucinations. So for their brain, it's real. And so if the mild cognitive impairment has passed through that point where they no longer have insight of like, yes, I have Parkinson's disease, and sometimes I have hallucinations because both the disease and the medication, then there's no amount of you talking to that PD brain and saying those little kids or those little people or the ants on your food are not real, because the brain is seeing them, so that for that brain, it's totally real. So then the best thing to do is to go along to get along. So you say, oh, like they want to set set the table for like the two kids that aren't there. So you'd be like, okay, here, let me put the I'll set a table for them, or I'll take these two kids into the other room and they can, eat dinner watching TV or something. So don't try to explain it away or rationalize away, because it's just going to be frustrating for both the caregiver and the patient, and you're not going to reach any kind of consensus. So if you find like, oh, they helped me unload the dishwasher, but they put all of the dishes in the microwave, just say, thank you for helping me. And then you just take them out and put them where they're supposed to be, because they're trying to help and trying to tell them otherwise, it, it just, that doesn't work.
Okay. And Kelly did put the link in the chat, but maybe Kelly, could we do a quick screen share of that resource so people can get a sneak preview, and make sure to save it from the chat. Um,
Right. So always we want to divert. So remember, they're going to get stuck on something, and then you're not going to be able to rationalize the thing away. And so you want to divert them to another task, to something else, instead of trying to be like, no, this is the wrong cloth for these dishes or the car or that sort of thing. And so that way you can sort of redirect them, because they're not going to be able to rationalize their way out of, or problem solve their way out of that. Mm-hmm.
okay.
And so like now, now it's 100 degrees outside, and many times, we'll have patients where like you're taking them to the dentist, but they won't want to get out of the car because there's like the two kids are in the back seat and we can't leave them in this hot car. And so instead of trying to tell your loved one that there isn't anybody in the back seat, that the grandkids are not in the car, or that you don't have grandkids or leprechauns or that sort of thing, you just say, okay, I'm going to take you up to the dentist, I'll put you there, and then I'll come back down, and then I'll pick up the kids afterwards. And so that way you sort of like take care of it that way, instead of trying to explain to them that there aren't any kids in the back seat.
And I think your explanation that the frontal lobe isn't connected anymore. They're not choosing to argue, or
Right.
it's just not possible anymore. So thank you for that, and hopefully
And
it
and
can
so
help.
Right. And so think of it like as we grow older, think of it, it's like the movie runs backward. Remember, like when you had kids and what those, it was, for those kids to grow up, from a baby, basically dementia is that movie running backwards. And so remember how your toddler would get frustrated and irritable if they didn't get enough sleep and enough food and take their nap, or they were frustrated because they couldn't figure out something. The same thing happens with a patient with dementia. And so that you need to realize, oh, if they can't do something, it can be frustrating. And so you just want to sort of let it rest and move on to something else. And that with time, they sort of need more help with activities of daily living. So yeah, they were putting on their shoes and socks and, buttoning a shirt for the last 82 years, but now it's all, in the wrong order and backwards. And, that's sort of the movie running backwards. So to try to tell them like, well, you've always been tying your shoes. Why don't you remember how to tie your shoes? You just get, slip-on shoes without laces, and those sorts of things. If they can't figure out the buttons, then get a shirt that doesn't have buttons. It's like remembering when you had little kids and you're trying to get them out the door and get their shoes on, and it's the same sort of thing. And that the same sort of frustration, anger outbursts, it's the same because the brain can't deal with too many inputs. It can't do multitasking anymore. So many times patients will notice, or family members will notice, gosh, I can't ask too many questions all at once, and I need to ask more yes or no questions, because if I ask a multiple choice question, they cannot give me a choice. The brain can't do that anymore. So it's just easier for me to say A or B, yes or no, instead of having them make a choice.
So for those people with Parkinson's who are, listening to your answer and imagining their movie running backwards, that is scary, depressing. What are things we can do to keep that cognitive function and, be proactive?
Right. And so remember, the best thing to do is to empower yourself and like gain knowledge and plan ahead. So we know, what's happening in Parkinson's, those little neurons that produce dopamine are dying off for whatever reason. They're dying off. And we want to keep them living as long as possible. Today, all of our therapies are purely symptomatic. They don't stop or reverse the disease. They just treat the symptoms. And of those, it's only the motor symptoms, and they make cognition worse. So we know that physical exercise and aerobic exercise makes those little neurons make new connections. The more connected they are, the more robust and healthy they are, the longer they live, the slower the progression of the disease. If you have Parkinson's disease and you start to notice, gosh, I'm already having some hallucinations, I'm already having some trouble keeping my calendar, multitasking, then you want to plan ahead. So you want to make your life as easy as possible and simplify it as much as possible. So, if you have PD and you're 80 years old, you're not going to go buy a house that's 6,000 square feet. You're going to downsize and make it a house that's less landscaping, less upkeep, and make it easier for you to manage. So don't make your life more complicated, make it less complicated and plan ahead. And so, if I need a caregiver, where am I going to find that caregiver? How am I going to pay for that caregiver? Am I going to need assisted living? Those sorts of things. So the more that you plan ahead, the easier these transitions are going to be, because you don't want to be making these choices at 3 o'clock in the morning in the ER after you fell and you broke your hip. And you're too confused and you're too impaired to go back to your house where you live by yourself.
I don't think any good decisions are made at 3 a.m. in the
No,
ER. No.
but if you plan ahead, then if you do, fall and break your hip and end up in the ER, then you have a plan of like, okay, if I can't go back to my own house, then I know where I'm going to go and like where my dog is going to go and all of that. That way there's less stress for you. So plan ahead, encourage everybody to get a living will, a financial power of attorney, a healthcare power of attorney, so that these decisions are made ahead of the time, not in some ICU with like kids who are flying in from the East Coast who don't know anything about what's been going on and have to figure out everything the day of.
Great advice, as well as exercise. Is
So,
there
and
ever
exercise. So remember, so right now, all we can do is exercise. Basically, to live well and to live with Parkinson's disease, everything you learn in kindergarten is what you need to do. So you need to exercise. So go out and play at recess. Eat your vegetables like your mom told you. So we need lots of fiber and good food to feed the brain. We want to take a nap to keep that brain nice and well rested and working well. Remember, during sleep is when the brain is doing all of the housekeeping of the brain. It's getting rid of all those misfolded proteins and toxins and cleaning up, doing the housekeeping of the brain. And that only happens during deep sleep. So you don't want to miss any sleep. And if you need to take a nap during the day, you want to do that. And then the other thing that you learned in kindergarten was play nice with others. So the more robust your social circle is, the better off you're going to be and the better able you're going to be to manage these stressors as they come. So like somebody's going to be there to take care of your dog, to make a meal for you, to figure out what assisted living is the closest for you, or to help you with grocery shopping, that kind of stuff.
Very good. And that answers a question Risha had about, are naps good for brain health? So,
Yeah.
but in the right dosage, like most things, right?
Right. So you don't want your nap to be all day long. So, and remember that PD patients sort of like have this circadian rhythm where between 2 and 4 in the afternoon, they don't seem to do as well. The meds don't work as well. So like that's the perfect time to take a nap. And then naps are restorative. So think of a nap and sleep as a medicine for your brain, because there's just like you have your lymphatic system that takes away the toxins and everything. In the brain, you have the glymphatic system, which is what takes away the misfolded proteins and all those other toxins. And remember, during deep sleep, that's when growth hormone is being sent out. And so like if you sprain your ankle, the healing is happening during that time. Your short-term memory gets consolidated into long-term memory during deep sleep. Learning and memory, all of that takes place during deep sleep. So sleep is, remember, we spend a third of our lives asleep. That's about 30 years if you live out a normal life. So something really important is happening if we're going to be asleep 30 years. So it's not something to shortchange yourself on.
That's a great way of looking at it. I never thought of it like that. Must be important if it's
Right.
years. Okay, let's see. Jenny Campbell had a question about freezing of gait does that indicate too much or too little dopamine? And she also has DBS and is experimenting with changing the amplitude to help with freezing of gait.
Yeah, so the freezing of gait is common in PD. So many times it's associated with off periods, but even if you're on, you can still have freezing of gait where the feet get glued to the floor in narrow spaces, crowded spaces, like you're going into the laundry room or the bathroom or the closet, trying to make a turn. So the freezing of gait, even if you're on, can happen during those times. It doesn't respond as well to DBS as we would like. But if we can keep you on, then many times we can treat a lot of the freezing of gait that happens when you're just sort of walking. The freezing of gait that happens in narrow spaces and crowded spaces, we can deal with sort of sensory cues. So you use, like a metronome or a laser light to give you a visual cue of something to step over to unfreeze the gait.
Sounds good. There was a question about MCI or mild cognitive impairment, not the old phone company. So, does
Yeah.
mild cognitive impairment always progress to dementia in time?
Not necessarily. So, I mean, you could have MCI for a long period of time. So, mild cognitive impairment, it just means you have some difficulty, with short term memory, word finding difficulty, but you're not completely impaired. You don't need a caregiver to take care of everything. That you definitely will notice more bradykrinesia with the bradykinesia. But again, the more we exercise and eat sort of a brain healthy food, which is lots of fruits and fiber, sort of anti-inflammatory Mediterranean diet, the better off we're going to be.
Okay. Let's see. Someone asked, and this is a hard one, but you can handle, do the pump therapies reduce hallucinations?
So they can, if your hallucinations are happening because they're just all med induced, so that we're going above your therapeutic window and it's too much dopamine for you and that's causing the hallucinations, then if we can keep you below that therapeutic window, then that, like impulse control disorder, is going to get better. You can still have a hallucination. Let's say you're well managed on the pump, so that non-motor symptoms like your hallucinations, impulse control disorder, urinary urgency is well controlled, but you develop a UTI, then that can push you over the edge and you can see more confusion, hallucinations while you're having that infection, more urinary urgency, and then you sort of go back to baseline. But I think that's why we're so excited about the pumps, is that we know that the more we can keep you on and in your therapeutic window, the better off you're going to be. Remember, we don't want patients to be living their life around every single dose of levodopa. So we want to tailor your therapy to your disease, not to sort of tailor your lifestyle around your disease. Does that make sense? So we want to eliminate the 5-6 alarms on your phone. We want you to stop, planning everything around every single dose of medicine. And we want you to go out and live your life and then tailor, use on-demand therapy, use the pump so that you can go and do things that you need to do. And we think that if we can keep that brain on, so like think of a light bulb. What if we were turning that light bulb on and off every 20 minutes for 10 years? That's going to like fritz out the light bulb. So probably the same thing is true in the brain. Like if we can keep those receptors nice and stable and they're not going always upregulating, downregulating, I think that they're going to do a lot better. And we're going to keep a more stable brain for many more years than we can do now with immediate release levodopa.
Okay, and as we're talking about the new pumps and these newer drugs, Annie has an important question or a comment. So, that they exist is different than being able to have access and afford them.
Right.
So she wanted to know, can you comment with the newer drugs or pump delivery systems about whether insurance is covering them or not? The cost is often prohibitive, and it's better to know that in advance.
Yeah. So, in Europe and Australia and everything, the pumps are all that taken care of by the National Health Service. in the US, we're actually going to be lucky with the pumps because the pumps like DBS are going to come out of your Medicare A and B. So it's going to be covered by your Medicare, and it's not out of your Part D, like the oral medicines where you have a copay because it's an oral medicine. So once you get it approved by your Medicare program, then it should be paid for by Medicare, and you should not have an out-of-pocket expense. Because you have Parkinson's disease, the only criteria to get a pump is to have more than 2.5 hours of off time. So almost everybody, except somebody who's newly diagnosed, would qualify for a pump. So right now we think that because the pump, you have to carry the pump around and it goes through the skin and you can develop skin issues. We always want to make sure that the benefits of the therapy or the medicine outweigh the side effects. So if it's still easier to pop a pill 4 times a day of Crexont, we're going to do that. And then your 5th dose of medication should be a pump, because then it makes sense that I'm going to put up with carrying a pump and any skin issues to get the benefits of having continuous therapy. So it's just a matter of doing, the prior auth, the appeal, and just like we do for DBS.
And also want to say, Annie, I don't know if you have Medicare and there's all the Medicare Advantage plans. Maybe you still have commercial insurance because you're working or a spouse is. So it's tough to talk about all insurance, but appreciate that, Dr. Ospina saying that because it is a device, it's different, it's covered differently from oral medications. And also want to share on the PMD Alliance website, we have resources with all of the different financial assistance programs. We have resources on how to choose your Medicare plan, how to weigh between a Medicare Advantage, what's right for you, and some tools about you can even type in the drugs that you're on or the drugs that you want to be on and see if it would be covered under prospective plans. So, because like you said, Annie, real talk, it's different that they exist and that you're able to have them. So thanks for pointing that out.
So even now, so Part D, so I've seen like several questions about the Crexont. Yeah, so today, before it was prohibitively expensive to have a PD patient on multiple branded medicines. It was just not affordable. Today, your Part D is capped at $2,000. And once you meet that $2,000 deductible, then all of your medicines are free. So it makes using branded medicines like Crexont or Ambrosia much more affordable in Parkinson's patients. And then you can still leverage, like you said, the PAN Foundation or other foundations to cover the $2,000 deductible.
Okay, we had some more content questions. Okay, between the 2 new pumps, Onapgo and Vyalev, which is most effective at optimizing on time versus dyskinesia?
Yeah, so they're both excellent. So both of the drugs, you can have continuous dopamine tone. So it's all going to come down to skin issues. So some patients are going to tolerate phospholevodopa a little bit better than apomorphine, and some people will tolerate apomorphine much better than phospholevodopa. But the fact that you're getting continuous dopamine tone, that's the key. So it all depends, some are just easier to use than others. So the apomorphine pump, you can be titrated at home with a nurse and you add it on and then slowly taper off your other medications. Whereas phospholevodopa, the Vyalev pump, you have to switch over all your levodopa at once and then get titrated fairly quickly. And so, just depends. But the key to the pumps is continuous dopamine tone. And so right now it's a little bit easier probably to get apomorphine approved. But once they're both on CMS, it should be just like Duopa or DBS.
Okay. Okay. So Wayne and Elaine wanted to know, does most of what you just taught us about dementia also apply to Lewy body dementia?
Yeah, so in Parkinson's, so there's Parkinson's disease dementia and Lewy body dementia, but when you look at the brain under the microscope, they all look the same. In Parkinson's, they all have Lewy bodies. We say if you develop dementia within your first year of diagnosis of Parkinson's disease, that's called Lewy body dementia. If you develop dementia 15, 20 years later after your diagnosis, we call that Parkinson's disease dementia. But if you look at the brain under the microscope, they all look the same. They all have Lewy bodies. So Lewy bodies you would see in Parkinson's disease because that's the misfolded alpha synuclein, whereas in Alzheimer's disease, you would see beta amyloid plaques and tangles. So it all depends like what the protein is that's misfolded.
Hmm. That answers another question about whether there's a test such as the DAT scan to determine whether it's dementia or Lewy bodies.
No, so the test is like your neuropsych testing or your clinical exam. The DAT scan, what that measures is dopamine transporter in the brain. So it can tell us even before you develop your motor signs of Parkinson's disease, whether or not you have idiopathic Parkinson's, like you have dopamine loss, whether it's Parkinson's disease, MSA, or Lewy body dementia. The DAT scan is going to not be able to tell you whether it's one or the other, just like neither the skin biopsy that's done with the clinical exam. And then, remember, by the time you walk into your neurologist's office with tremor, rigidity, gait imbalance issues, 60% of those cells that produce dopamine have already died off. So you've already had Parkinson's disease 10 or 15 years before you walk into the neurologist office. And many times we can pick it out early on with either a DAT scan or a skin biopsy. But right now we don't have that missing piece of the disease modifying agent where we can stop it there and slow down the progression.
And that's connected to a question. So are the medications you would use to treat someone with Lewy body dementia different from Parkinson's?
So we would add memory medicine, so things like the Exelon patch or Namenda or Aricept. So those are meds that we would also use in Alzheimer's dementia. But these are medicines, they don't stop or reverse the cognitive decline, they kind of slow it down. And so they're not as beneficial as we would like it to be. Yeah, and I think, not only in Parkinson's disease, but just with normal aging, I can't stress enough for patients to sort of, organize everything to make it easier for them. And so to have a living will, to have a healthcare power of attorney, to have a financial power of attorney, to like let your kids know where your passwords are, like where the checkbook is, so that if you're impaired or incapacitated, whether it's PD or you had a stroke, like somebody can still keep the lights on in your house and figure out how to pay for the caregiver and your dog and take care of your dog and that sort of thing. So just planning ahead is just good for normal aging as well.
Okay. Well, I like what you said. It's a good closing and a good way to remember and refer back to everything we talked about that, the goes back to what you learned in kindergarten about
Kindergarten, right.
eating healthy, having friends,
Having
uh,
friends, being nice to other, exercise, go to recess, and take a nap.
take a nap. Yes. So we covered so much. I think I'm going to go back and watch this recording. It'll be up on our website and our YouTube. Someone said that when they watch Dr. Ospina recordings, they put it on 0.75 speed because you talk so fast. So I can see that. We covered a lot. But thank you for
Sure.
rapid fire answering all of the questions we wished we had enough time to ask in our doctor's offices. We didn't get to everything, but that's why we do these all year long. And so just want to close right in 1 minute nick of time by saying thank you to Dr. Ospina. Thank you to all of you for really good questions. And let's give Dr. Ospina a wave of gratitude and a wave of gratitude to all you too. So nice to learn and be together on Zoom today. So thank you, Dr. Ospina.
You take care. I'm happy to do another one if patients have more questions.
Okay. Bye, everyone. Have a great afternoon.